Good morning. We're so happy to have you here with us this morning. I'm Hannah Belcito, Chief Experience Officer at Destination Cleveland, Cleveland's destination marketing and management nonprofit organization. We're excited to partner with Association Forum for another healthcare collaborative session. The travel, tourism, and hospitality industries have been significantly impacted by the pandemic across the globe. We're standing together with our industry near and far to support its recovery and regrowth, both in the short and long term. Consumers seek assurances that destinations and the businesses within them are committed to help ensure their health and safety. In Cleveland, our word is our bond. Our Clean Committed program asks businesses for their word to help ensure a consistently safe and responsible reopening of Cleveland's hospitality, entertainment, and tourism industries. The program requests a voluntary commitment to a standard set of cleanliness practices developed in partnership with our region's healthcare experts at the Cleveland Clinic, the Metro Health System, university hospitals, and both the City of Cleveland and Cuyahoga County Board of Health. In less than 6 months, more than 700 local businesses have made the clean commitment, giving their word to customers that they're standing together to help ensure customer safety. All clean committed businesses are listed on our website at thisiscleveland.com and being promoted to consumers through our owned, earned, and paid media campaigns. In addition, we've distributed nearly 175,000 clean kits to businesses and directly to consumers. Each kit contains a 3-ply mask, Purell Singles advanced hand sanitizer packs, and safety information cards. We're excited to be able to provide each of you with a clean kit to use when visiting your favorite hospitality businesses. Now, I'd like to introduce today's speaker. Dr. Nizar Zein is the chairman of Global Patient Services, an inaugural endowed chair, and director of the McCarty Foundation in Liver Diseases at the Cleveland Clinic. Dr. Zein is also a member of the Board of Governors and Board of Directors at the Cleveland Clinic. He's received several awards, including the American Liver Foundation Scholar Award, the Cleveland Clinic Innovation Award, and the Distinguished Faculty Award for Research Mentorship. Dr. Zein has been recognized for academic excellence by the Syrian American Medical Society and honored for his leadership and community service by the Ana G. Mendez University of Puerto Rico as the recipient of the Presidential Medal in 2011. In his role as chairman and medical director of Global Patient Services, Dr. Zein leads a multidisciplinary and multinational team of caregivers that ensure all international patients at the Cleveland Clinic receive high quality and seamless care. During his youth, Dr. Zein lived in Greece and spent extended periods of time in England and the United States, and can trace his passion for the global patient back to his childhood. At age 13, he accompanied a relative with a heart defect from Syria to the Cleveland Clinic and has since been passionate about quality and compassionate care for international patients. Thank you again for joining us today, and please join me in welcoming Dr. Zein.
Thank you very much, Hannah. Thank you all for taking the time to listen to my presentation. I'm honored. I'm happy to speak to you for now virtually, and hope in the future in person. I would like to share my slides and begin the presentation. All right. I assume you can see my slides, if anybody can confirm. Okay, I'm assuming.
Very good, Dr. Zein, we can see them.
Oh, great, perfect. So I was asked to talk a little bit about the future of medical tourism and the impact of COVID-19 on it. And I'm gonna go back and forth to the industry of medical tourism, what it means, why we do it, and how COVID had a massive impact on medical travel for medical care, and how we believe we will and should recover. And I want to start by first highlighting a very important distinction, not to confuse global health with international health. And the difference is straightforward. That is, what we will be talking about today is more global health, in which there are shared medical problems globally and provide solutions for these problems. This is different than international health, where it is focused on refugees, natural disasters, wars, and so on, and immigration and related issues. So we are talking more about global health. And medical tourism is part of that entity called global health, where there is sharing of knowledge, there is direct patient care, there are experiences in care delivery and technology that get copied or modified in different locations globally, and common diseases that we all share burden of, such as COVID-19. So to start, I am gonna make a few points. The first of which is that medical tourism actually makes sense. And the reason I say that is that the threats to human health are globally shared. On this slide, on one side, you see figures from the Spanish flu, where millions died in about 100 years ago. And on the right side, other diseases beside pandemics and epidemics, such as impact of climate change, impact of losing green space globally, impact of not having fresh water available, and so on and so forth. All of these factors impact human health and are shared globally. So it's not only infections, it is far beyond that. What is also shared globally in the recent past are the epidemic of obesity, diabetes, heart disease, stroke, Alzheimer, malignant tumors, autism, and the list goes on. These diseases highlighted on the slide have had significant impact on human health and human longevity everywhere in the world, and are not unique to one particular location. What is also global is how we manage health. We have everywhere you look globally, there is aging population, increased prevalence of chronic diseases, particularly that of diabetes, COPD, and cancers. Yet patients becoming more and more sophisticated and aware of their options, but sometimes these options are costly or not accessible to populations. So and yet, despite all these shared medical issues, access, quality, safety, and experience in healthcare are anything but universal. So we have common problems, but access and quality of healthcare is very much different from one location to another. This is really why traveling for medical care may make sense to different populations at specific times in history. Second point, as an introduction, I wanted to make that if anyone believes that we are not going to recover from COVID-19, I think you need to think twice. Travel for medical care, or what we call it medical tourism, is an ancient industry. We did not invent it, nor our parents or grandparents invented it. It's very ancient industry that have survived all possible challenges. The photos here are photos of from Asclepios, which is a treating facility in the city of Epidaros in Greece, which is what I'm going to talk about here. So I'm going to show you some examples, and we start with the Asclepios sanctuary in Epidaros because it is actually the oldest well-documented healing center for which people traveled from many different locations around the world, around the Mediterranean, have traveled to receive medical care. So it dates back to the 2nd millennium BC, made invaluable contributions to medical evolution and advancement, especially in shifting the philosophy of healing from prayer-based healing to science. So it really was the top center for medical care of its time. And it is the earliest documented formal medical tourism activity. If you move forward in history to Cairo, Egypt, Mansour Hospital, 1248 AD, at the time was the largest and most advanced hospital globally. It had 8,000 beds, much larger than the Cleveland Clinic main campus facility, had a formal department to facilitate medical care of foreign patients seeking help. So it is the first documented medical facility where they established a specific department to care for foreigners who needed medical care and traveled from other countries. This was published in 2017, a paper by David Shans. And in that paper, they put the policy statement that, by the way, this hospital continued to exist in Cairo, Egypt. I believe it is an eye hospital, ophthalmology hospital only. This is their policy statement that apparently still sits at the entrance of that hospital to date. And it read the following: the hospital should keep all patients, men and women, until they are completely recovered. All costs are to be borne by the hospital, whether the people come from afar or near, whether they are residents or foreigners, Muslims or not, strong or weak, rich or poor, employed or unemployed, blind or sight, physically or mentally ill, learned or illiterate. There are no conditions of consideration and payment. None is subjected to or even indirectly hinted at for non-payment, the entire service through the magnificence of God, the generous one. So this is again 1248 AD. Moving a bit closer in history, south of France. In fact, all the small villages in south of France that we all love to go and visit if we can, in Nice and Cannes and the Monaco area, all these evolved because of medical tourism, with the discovery of mineral water in that region that created economic boom and the rise of these small villages at the time into places where people traveled for medical care. Prominent visitors like Peter the Great and Victor Hugo visited these wellness resorts, and a lot of the rich and elite in Europe made it an annual visitation for them for healing and medical care. And finally, in terms of history, is the city of Bath is fascinating. Around 1720, aristocrats from around Europe flooded Bath for healing and therapeutic cleansing. In the 1720s, Bath became the first city in England to receive a covered sewage system and was ahead of London for several years. Roads were paved, streets had lights, hotels and restaurants were beautified, all because of medical tourism at the time. So it created a booming economy for that small city in England that made it far ahead of London in terms of social and economic development. So with that history, I just wanted to review the history to say COVID-19 is not the first pandemic, nor it's going to be the last. It's not there had been other infections, but also natural disasters, wars, and everything else in between, yet travel for medical care continued. So I go back to say we will recover from whatever the impact of COVID-19 has done. In modern time, the medical travelers no longer primarily from around the Mediterranean who went to to Greece for medical care, or in Europe who went to the city of Bath or south of France. Today, they come from a number of places, but the largest number of medical travelers globally are those in Latin America, followed by Middle East, then Europe, Canada, and others. So this is where they come from in modern time, from many places. There is some increase in that activity in China, but they are still small numbers. And if you look at the drivers, what makes people travel today for medical care, it is often cutting edge technology, better care, and quicker access. And I bring these up for a number of reasons, most of which is important in terms of trying to think of recovery after the COVID-19 pandemic. So what drives people to travel for medical care should be our focus. There are a smaller proportion of people, particularly in the United States, that travel outside their border for medical care because of lower cost of care. But again, that's still a smaller driver of travel for medical care at the present time, at least from a US perspective. So why do hospitals like ours, the Cleveland Clinic, why do they participate in caring for foreign patients? What is the value proposition for us and for other hospitals? Would be? The value proposition is multiple, but this is some of it. For healthcare organizations, it extends the longevity of an organization by global extension, leading to growth. The famous say, no growth, it would not survive. You have to grow in order to survive over time. It improves local and national standings of hospitals. This is based on a lot of data. So for local patients, for American patients who hear that people travel from China, Middle East, and Europe to Cleveland Clinic or Mayo Clinic or Johns Hopkins for medical care, it makes them, if it is good for people to travel across oceans to come to this place, it's probably good for me who I locally to go to these places. So it improves their local standing. It reduces dependability on local markets, and it's destabilizing elements such as reimbursement. I'll show you a graph on that. Promote global economic growth, and some people would argue it based on the two articles referenced that it may promote democracy in some places due to intermingling and becoming more tolerant culture. But as important, it is mandated by ethics of knowledge sharing, especially as the US is leading the world in medical innovations. So these are some of the reasons why there is value in participating in it. From the financial point of view, which is obviously very important, if you look, this is data from 2016 Medicare Medicaid annual report, looking at operating margins of S&P 500 companies compared to all healthcare companies. And if you look in the past 2 or 3 decades in the United States, and while operating margins have significantly grown for many industries, it has steadily declined in healthcare. In fact, healthcare has very, very narrow margin in terms of operating a hospital. And this is part of the reason why we saw the expansion of hospitals in the US, meaning mergers and acquisitions and expanding the patient base because of these low margins. So participating in international medical care helped to address some of these local issues. Another piece of it, consistent with what I told you about the city of Bath in England, that caring for foreign patients is also an investment in the local community. This is a photo of my home city, Cleveland, that we are very proud of. what I'm showing you is not facts and not based on published data, but my own estimates, based using assumptions. Some of it facts, some of it assumptions. So at the Cleveland Clinic main campus, I'm not including our facilities in Florida or elsewhere. But we see on average 5,000 unique international patients. Average length of stay is about 2 weeks, although it can be as much as a year or two in cases of organ transplantation. I made an assumption on average when an international patient come here is typically accompanied by 2 family members, although we know that in many cases it's a lot more than 2. I also made assumption that the average daily spend on food is $100 per person. This is based on data from tourism data, and average cost of a hotel is $150 per night, with an average family occupying 2 rooms in the hotel. So these are the assumptions, not completely random, but based on data in tourism, not necessarily medical tourism. But what we also know, and that was referenced in these data, that on average, a medical tourist spend twice as much on food, lodging, and shopping than a non-medical tourist. So these would be quite conservative estimates. Based on what I showed you, if we look at what the contribution to the city of Cleveland, not including anything has to do with healthcare. So that is Cleveland Clinic and maybe University Hospital issue. So this is purely contribution to the city of Cleveland outside healthcare. So probably this population spent about $21 million annually on food, 140,000 room nights, totaling $48 million on hotel, transportation and other spend about 32 million. All in all, that population, not including shopping, would spend well over $100 million a year in our local city in Cleveland. So there is a value proposition even for the city where medical centers are located, not only for the healthcare piece of it. So how big this market? I think this is a question nobody is able to address at the present time, because definition of what makes a medical tourist is very, very much different. So some people include someone who came here for dental care or cosmetics, or even for medical spas, wellness, and other non-traditional type of medications, and others would exclude these. If you look at the McKinsey report, estimated that probably globally, this market has grown significantly to as much as $100 billion a year globally. However, if you look at the US market in terms of volume, not revenue, based on the McKinsey report, probably as many as 5 million people foreigners receive medical care of some sort in the United States. But if you take out expatriates, that's Americans who live abroad, if you take out someone who came here completely for business or for vacation, but happened to have gotten sick while they were in the US and received emergency treatment, dental, outpatient wellness, if we take all these together, probably 60,000 a year would come to the United States to receive complex medical care. And the only intention to coming to the US is medical care, no other reason to come here. And this is complex medical care. This is actually quite significant number. It may not sound like it, but it's quite a big number, especially if you put revenue, because it is very complex care. However, we talked about all the value proposition, but it is a balancing act between risk and benefit, and it's not all happy proposition. The medical tourism is susceptible to many things, particularly geopolitical events. is susceptible to currency changes. We have seen that very much. So as simple as the Turkish lira falls down and suddenly a lot of patients from Turkey stops coming to the US for medical care because the costs become significantly higher. Terrorism, 9/11. I will show you a graph on this. Change in governments, such as what happened during the Arab Spring, significant decline of travel for medical care from these countries. This is, I by no means intended to be a political statement, especially on the day of election or anticipated outcome of election. This is the title from the paper published in 2017, The Trump Factor and Protectionism. It may have had a benefit to some pieces of economy, it may not in others. Certainly in terms of medical tourism, it led to decline in medical tourism. Especially when there was ban on international NGOs. We saw in Cleveland Clinic a significant drop in patients coming from Middle East, particularly because now they had much harder time getting a visa to the US, even for medical reasons. The issues around Mexico at that time led to almost a complete disappearance of Mexican patients that do come up here to receive medical care in our facilities. So these are factors beyond our control. They may have very good reason, but certainly in terms of medical tourism, was not was complicated our ability to continue activity at the same level. There are susceptibilities to local changes in healthcare. This is a classic example. This is from from Oman, where they used to send nearly 100% of all cancer patients to abroad for medical care. Then they built a very sophisticated facility working with French hospitals. Louis Pasteur built a cancer treatment facility, including radiation, chemotherapy, surgery, research center. Few years later, this is how much they send abroad for cancer care. So these are all factors will affect how this particular industry go. With those, with these challenges, I thought it would be now a good introduction to say a few words about the COVID-19 factor. So the COVID-19 factor is not only the pandemic. It was the COVID-19 led to a health pandemic globally. Health pandemic was followed, and we continue to struggle with so-called economic pandemic driven by the health pandemic, lockdown, shutdown of businesses, and so on. And in the middle of all of that, we have the racism pandemic that may have started with the death of George Floyd in Minnesota, but it spread globally. It was not only spread within the US, but you saw riots in Middle East, in Europe, in even Asia. So we had all simultaneously health pandemic, economic, and racism pandemic all at the same time. And so what did that do? So I put this, this is Cleveland Clinic main campus data. So it's not, again, doesn't include our facility in Florida and so on. But the bar figures would represent 2020. And you can see, this is, I assume you can see my pointer, but in February, you can see on that particular month here in main campus, we saw nearly 460 unique patients. And that is the beginning when we started to talk about COVID and COVID hitting the United States. And you can see the decline month after month. If you look at new patients, these are patients who have never been to Cleveland Clinic before. Same story, from about 100 patients to almost disappearing completely. The lines on top represent these same volumes in 2018 and 19. So you can see the gap between the green bars and the lines above, all this gap would represent how much of that particular market disappeared. And I'm using Cleveland Clinic, and I would argue we actually weathered the storm better than other locations. And despite that, you can see we lost as much as probably 80% of this market due to COVID. And that, of course, would be the same if you look at total encounters or net revenues associated with it, significant decline. And the only reason we didn't go down to zero, you can see still some activity, honestly, is mostly emergency cases extremely complex that truly nowhere else they could have been seen outside the US, and within the US in only handful of locations could manage such type of problems. And also some residual patients who arrived before the lockdown of COVID, and some of them got actually stuck in the US. They couldn't return to their home country, so they remained. So we kept account of them and provided them with medical care. So when we talk about recovery, I don't know when that will happen, but I want to show you, this is data published by an organization called USKIP. We have similar data from Cleveland Clinic. On the left side of the chart, we're looking at what happened after 9/11/2001, after a terrorism attack, 9/11. Looking at total tourism to the US and then looking at medical tourism independently. Please note, total tourism numbers are in millions, while on the medical travel in thousands. So it's not the same scale, but just to be clear. So let's say prior to 9/11, the United States received as much as 25 to 30 million tourists a year. And you can see what happened 2001, right after terrorist attack, 2001, 2, 3, 4, and so on. However, I mean, as bad as it may look, a recovery took place over the following 4, 5, or 6 years. So by 2007 or 8, we had achieved pre-9/11 tourism recovery and even started to exceed it at that point. When you look at the medical side of it, medical tourism, same decline, massive decline following 9/11, but we did not recover even 10 years later. In fact, Cleveland Clinic data would tell you that it took us 14 years to get back to the pre-9/11 volumes of international patients. 14 years, that is. I hope that will not be the case in post-COVID-19, and we are working very hard to make sure it would not be the case. So with that discussion over medical tourism, I want to tell you a little bit about our own story and go back to how we recover from this. So Cleveland Clinic went through an evolution over time to become a global organization. We were not a global organization when we started, but being global was part of our DNA, part of our culture. So started with international engagement. These are the 4 founders of the Cleveland Clinic, the 4 physicians who founded the Cleveland Clinic in 1921. On the right side is a picture from early operations where people came from particularly Europe, but from many places around the world to observe how Cleveland Clinic performed operations. In fact, since I spent significant part of my career at Mayo Clinic, I look at this picture and I find Dr. Charlie Mayo sitting in the back of that photo. But there were people here from multiple countries, particularly in Europe. If you look from the patient perspective, this is data from 1922, 1923, and 1924. Remember, we opened our doors to business in 1921. So only 1 year after, we saw patients from that many countries around the world. collectively, we saw about 70 patients in the 1922 through 1924. So about 70 patients or so traveled from outside the United States to the Cleveland Clinic for medical care. So what we do today, I did not invent, nor my CEO or my board invented. It's something that has been part of our Cleveland Clinic since its inception 100 years ago. Today, while at the beginning maybe we have seen patients from 10 or 12 countries, today we see patients actually from 140 or more countries around the world. So this is 119 countries only in Cleveland, Ohio, not including Florida. When you combine both, we see patients from over 140 countries every single year. So this is not one particular year, but every single year, patients travel from over 140 countries to Cleveland Clinic for medical care. Although clearly the big chunks of these patients come from Middle East and Latin America and Canada. Part of our evolution, we said it back in 1921, Cleveland Clinic in Cleveland was started. In '83, we expanded into Florida, but international expansion began in 2006 when we opened the doors of Cleveland Clinic Toronto, Canada, which is an outpatient facility, not a hospital. And in 2007, we took over the management of Sheikh Khalifa Medical City in Abu Dhabi, United Arab Emirates. Then Las Vegas came along, but internationally, our really largest project we ever been engaged in internationally is the Cleveland Clinic Abu Dhabi, opened door to business in 2015. If you never seen really an amazing facility, you have to see Cleveland Clinic Abu Dhabi. It's truly an amazing facility. This is the true picture of the facility. And more recently, been in the process of opening Cleveland Clinic London, which is scheduled to open actually next year for outpatient and the year after for inpatient. It is in a prime location in central London. So our international engagement evolved over time. We started to look into China, but still in early phases. Based on these physical facilities that we expanded, we can now say we are engaged, or we serve lives globally in many different locations. In each location, the circle where patients come from is significant. Beyond having large physical facilities like London, Abu Dhabi, and so on, we have also offices in many countries where they help patients, facilitate patient experience, and facilitate patients who wish to come to Cleveland, Ohio, or to Western Florida, where we have facilities for medical care. So our global footprint is beyond just the London, Abu Dhabi facilities. So with that a global presence, it is very important for us to maintain that global engagement and to recover from the post-COVID-19. And recovery is complex, but I'm going to show you some of the work we did. Early in March and April of this year, we established a COVID recovery team focused on the international piece of our activity, that looking at what we can do short-term and long-term. So when time comes, we don't have to wait 14 years like we did back after 9/11 to achieve the recovery that for our own economy, for the needs of our patient, provide access to international patient, and for our local city where we are part of our local communities. And without going through every piece of it, but in the short term, we would focus on preserving what we have done best over the years, but longer term on expanding our footprint and offerings internationally. We also thought extremely important is to focus on international patient experience, something that have not been much talked about globally, something that, for the lack of other expression, probably the concept was invented at Cleveland Clinic years ago in the sense of having had the first chief patient experience officer and having established a formal department to oversee patient experience. But even though we were pioneers in that aspect, we really have not done much on the international part of it. What we know today that when patient experience is improved, and there are many ways to measure it, most commonly in the US is measured by what we call it HCAP score beyond this presentation. But when patient experience improves, mortality is lower, readmission rate is lower, and hospital-acquired infections are lower. Besides patient experience, we put a plan to have regional strategies. So we, I don't need to dwell on it, but dynamics of healthcare are very different. For example, if you look at Latin America compared to Middle East. In Latin America, the population are heavily driven by self-pay or international insurance, while in the Middle East is government-sponsored healthcare. And the dynamics different, so you cannot have one simple strategy for COVID recovery that applies to all. We also have a unique advantage of having all the facilities and offices I showed you globally in as many as 10 or 12 different countries around the globe. So if we can put together an integrated global system that a patient, an international patient, can float through the system that is based on their need, can be seen in Cleveland or Florida, or can be seen in Toronto or in Abu Dhabi, seamlessly, and without each of these facilities operating as an independent facility, we will be providing unique value to international medical care that otherwise probably very few organizations today globally can provide. And finally, a focus on innovation. And the innovation means many different things, but I'll tell you why focus on innovation, because probably this is where the United States can compete the most with any other healthcare system outside here. And I based that on on a study actually recent published, that there is the notion, which is true notion, that the US health care system from global perspective is very expensive, but yet high quality. So we have to take advantage of the high quality and try to address the issue of cost of healthcare. And if we can do both, probably no one else could compete with the United States for care of international patients who wish to travel abroad for medical care. This is a study published in 2015, which was a cross-national study, compared healthcare spending, supply, utilization, prices, healthcare outcome in between the US and 12 high-income countries listed below. So these are really countries with strong healthcare system. What they found that the US is the highest spender on healthcare, but yet the outcome, for example, of cancer care or complex medical care is also the best among all these health systems. So if you take that into account, you can think of a model in which the United States can continue to focus on innovation, artificial intelligence, delivery models with high patient experience, while systems outside the United States continue to focus on efficiency and rational use of technology and population health, and accordingly create some sort of an exchange where we learn from their efficiencies and they learn from our innovations, or we serve our patients with complex medical issues with our innovations, while they could provide value for us in managing large population efficiently and more costly. So the way we think about it is that it is an exchange. It is not the United States or American healthcare facilities will tell people how to do medicine or will provide something no one else can provide. Rather, we have our own strength and weakness, and they do as well. And this exchange will probably be a win-win scenario. And this was part of our rationale to go abroad with healthcare facilities so we can learn and bring back home what we learned. But all what I told you is summed up in this. This is a true patient of ours, an international patient from El Salvador, a child with a cancer that was deemed incurable and was supposed to have died at home. Through travel for medical care, without going through details, the patient made her way with the family to Cleveland, received treatment, stayed here for several months, maybe as much as a year, was cured from her cancer, and returned home. And when she returned home, she sent us this photo saying, I miss you, Cleveland Clinic. And she was actually on the beach. So this was done on the sand on the beach. So it really, you can think of it as a business. You can think of the economic value. You can think of innovation, but it all comes down to the patient. And if we contribute to the better outcome and life of one patient, I think it makes it all worthwhile. And it gives us all the motivation of wanting to recover from the impact of COVID to continue this global interaction. With that, I'm going to stop. And once again, really grateful for the opportunity to speak today and be happy to address any questions to the best of my ability.
So much, Dr. Zein. At this point in time, if anyone has any specific questions, please use the chat feature to communicate those to us. Dr. Zein, I'll start with one kind of spurred by the last photo that you shared, and that is how are you guys how are patients globally finding the Cleveland Clinic for that care when they might not be able to access the same level of care in their home countries? Are you guys actively marketing? What is the method for kind of getting the word out? And then as a follow-up to that question, what is the funding model for care? Are they self-pay? Is there a level of, pro bono work that Global Patient Services does? But just in terms of some of the mechanics of attracting the patients when the time is right, again, obviously when we can travel more, and then also just the nature of the type of revenue that flows from these patients.
Yeah. So these are multiple questions, and thank you. I would say first to the issue of how do patients find us, and I think if you look historically, the majority of international patients who came to our facilities, they come through word of mouth and physician-to-physician referrals. We talked about the patient side, but on the education side, for example, we have trained thousands and thousands of international physicians. In fact, I looked at the data from I think 5 or 6 years in a row, and we had as many as 11,000 international physicians come spend anywhere from a week to 2 years in here in some sort of training. So some of these become ambassadors, and they are the ones who may refer their patients when they go home to us. But patient refer each other as well. More recent history, evolution of I would say middleman type of managers, where there are medical tourism companies and insurance companies that provide international products. They are doing some of that referral at this time. So it has changed over time So at the present time, I would say all of these contribute to how patients come to us. And in a small proportion of patients who are typically the more educated and sophisticated, they do research online about hospital rankings, about specific type of medical problems, and they find us and they go to our website and they contact us. But that's small proportion. The second piece of it on I think the second piece on whether we do funding and sort of how do they pay for it, because US healthcare is very expensive compared to anywhere else in the world. Again, based on, so most people assume that the patients that come here are wealthy, and I would say 80% of them are not. But they are not, but they have some sort of strong coverage of healthcare that would allow them to come. From Middle East is typically the government. So GCC governments, Kuwait, Saudi, Qatar, UAE, and others would pay full cost of their patients to come here and receive treatment if it is a medical problem that cannot be treated in their home country. On the other hand, if you look at Latin America, the large insurance companies have an international product. So the patient choose to buy it or not when they sign up for these international insurance coverage. And when they do, they are able to access us. With all that, we also do some pro bono care. So we do, it comes from multiple ways. Some of it is an international person who happens to be in Cleveland and not for medical care, happens to have, for example, gotten into a car accident or had a heart attack or whatever it is. We provide care even if they cannot pay for it. But we also, about 2 years ago, I oversee an international philanthropy pro bono fund, came from a donor, international donor, that we actually treat children with cancer, specific type of children with cancer, and, from other countries. We bring them to Cleveland, perform bone marrow transplant or other treatments. And we just, for example, send one patient back home after being here for 9 months, cured from leukemia, and completely free, based on that funding source that we established.
That's excellent. Thank you for sharing that. We have a question from Kathleen Bell, wanting to know, what's the demographic profile of patients? No matter who pays, what are the disparities between among various races, financial status, types of disease, etc.? And how does the clinic manage those factors?
So we provide medical care to anyone who is in need of our type of medical care. And for that matter, if you look at the demographics, I would say the most striking part of it is the complexity of care. There is actually a measure of complexity of care in healthcare. It's hard now to describe it, but there's a scoring system of how complex. Cleveland Clinic sees the most complex medical care of any hospital in the United States of America. And despite that, if you look at our international patients versus our domestic patients, our international patients' complexity far exceeds our domestic patient, which is already the most complex in the United States. So the most striking demographic of it is there are patients who truly need that care. It's very complex care. The second is if you look at the origin of these patients, like I said, GCC and Latin America combined probably make about 80% of these patients. I would say probably 20% of them is because they have their own wealth that would allow them to travel out abroad for medical care. This is reality. But for the majority of them, they have wealthy governments who are capable of paying for them. And we don't decide who from Saudi or Kuwait, we don't decide who from that country come to us for medical care. The government refer these patients. They have a healthcare committee local in their country who vet through all the requests and say, okay, you guys gonna go to Cleveland Clinic for medical care. So we are not partner in the selection process.
That's great. Thank you. To build on that question, we, Destination Cleveland, have worked with Global Patient Services in the past to, help provide information to families of patients that are there for an extended stay. And we've learned about your team, the Global Patient Services team. And I think it's a very interesting model, building on Kathleen's question. Could you speak a little bit about the different components of your team that support the patient through their stay? We know that Cleveland Clinic is an expert in patient experience, and that extends to the work you do treating global patients. So I'm just curious if you could speak to a little bit about how you meet that patient where they are from a cultural sensitivity perspective, from even helping, or referring them to partners we might have in the community for extended housing, things of that nature. It's really a complex system Global Patient Services runs outside of just providing the healthcare. You could speak to a little bit about the team that supports kind of this department and the general overall care for the patient and the family. That'd be great.
Thank you. I think it is a great question. If any one of us would think, most people had required some sort of healthcare in their life. Certainly I did. It is intimidating enough. It is complex enough for anyone who is even part. Even I've been working at the Cleveland Clinic for 20 years. It's intimidating for me to go as a patient and receive medical care. So if you look at that and then add the complexity of being from another country who never been here, being alone because my social support system is not there anymore. I'm in a foreign country. I don't speak the language. I don't eat the food they eat, and I don't have a car, and I don't have a cell phone, and I don't have a bank account. You can imagine the complexity of caring for that. So this is where Global Patient Services comes in. For one thing, we are language ambassadors. So we no matter whether they spoke English or not, we take care of it. Secondly, we have a patient experience / culture ambassadors that intend to bridge the gap in culture. And that bridge the gap culture could be as simple as a female patient who would only see a female doctor, or it could be a culture gap in terms of what part of your body would allow to be seen or not. And so there are a number of complexities. So we have people who actually, that's what they are doing for a living, and they facilitate that. We have a director of international now patient experience within Global Patient Services to help navigate through the culture piece. And I think this is the hardest piece. And I talk about the culture piece from the patient perspective. I can assure you it is as complex as from the provider perspective. That is, not all providers have empathy for international patients. Not all providers are happy to see international patients. A lot of providers have all types of stereotype ideas about patients from this country or that country. So part of our job is not only to bridge the culture gap between the patient and us, is to make our own employees and physicians and care providers also have empathy for these patients as patients, not as where they come from. To me, when everybody asks me what's your job, I tell them by far the only job, the job I take most seriously in my role is creating a culture of empathy for foreigners in the Cleveland Clinic. This is a big piece of it. Besides that, Global Patient Services work with local partners to provide all types of hospitality services. We don't provide it, but we connect the patient to the right. So transportation, housing, short-term, long-term, hotel discounts, a number of things that a patient we work with people who provide cell phone. If we have a bank on site at Cleveland Clinic where we can direct them to if they want to open an account and so on. So the role is fairly broad from culture to language.
Yeah, that's great. I mean, it's really truly a holistic model of care, not just treating the disease or the thing that brought them there, but the entire person. And I think that's unique and that's great. It looks like we have another question from Kathleen. Has having the Cleveland Clinic in Cleveland caused other types of service organizations to be established, churches, or so has having the global patient services in Cleveland caused other types of service organizations to be established? Like, there was not only Donald House serves families of pediatric patients, that's a need based on demographic. Is there any other organizations of that such that your work has directly influenced the creation of?
I think so. I mean, I'm aware of at least two so-called hospitality companies to start business, and their business is solely international patients and their families. So I think we can, if you look at even not all hospitality, but only limousine company or transportation company, a full company is focused on that one single population. So I can I don't know all the businesses that may have primarily existed to serve this population, but certainly few of them. I can tell you there was an article in the local newspaper in Cleveland some years ago with a photo that I have on a slide somewhere of a number of families from Middle East shopping at Beechwood Mall. And the title of the article with numbers actually, that Beechwood Mall would probably shut down its doors if the international populations did not come. And those were primarily patients and their extended families. I am aware of one particular patient, happened to be a royal family member and so on, asked me if I knew an art stores and so on. She goes, disappears for a couple hours, and what I heard that she spent over $300,000 or $400,000 in those 2 hours buying from local artists certain pieces and so on to reflect the local art stuff in Cleveland. So certainly it has impact. We don't know how to measure it all collectively, but yes.
Well, and Kathleen, I'll also just add that the Cleveland Clinic's main campus exists in one of the cultural hubs in Cleveland. And so there is just a lot of diversity and culture in that area for the patients that are there for a longer stay and can get out and explore a bit. We, Destination Cleveland, have also worked with Global Patient Services to ensure that we're providing them access to our content and materials for translation as appropriate by the Global Patient Services team to be given out. And I can share that we know at Destination Cleveland that a lot of the hotels, particularly one in particular, is by and large mostly always full with Cleveland Clinic patients and in particular international patients. So definitely an effect on the economy in that region and then compressing out into the suburbs. Dr. Zein, thank you so much. I believe that was our last question. What a wonderful presentation and a great end to the Healthcare Collaborative presented by Destination Cleveland. At this point, I'm going to turn it over to Gordon Taylor, our Vice President of Convention Sales and Services, to kind of close things out. But again, thank you very much for your knowledge and expertise and willingness to share it.
Yeah, well, I will echo what Anne Marie just said, Dr. Zein. That was an incredible presentation. You know, to be able to sit here and hear that, I feel really lucky to be able to hear your perspective on what the Cleveland Clinic is doing. And I'm sure most of all the attendees that were on here feel the same way. And I thought it was really interesting to see that picture from 1922, when you look back at 99 years ago and where the Cleveland Clinic is today as a global healthcare system. It's pretty amazing to see the journey. I particularly just personally loved what you said about that your most important part of your job is the empathy part. I think we hear a lot about empathy during COVID, and it's so important to have that characteristic. And it's just awesome to hear you say that. So we really appreciate your time. So this does conclude, as Anne-Marie was saying, our three-part healthcare collaborative webinar series we've had with the Association Forum. The power of our medical community here in Cleveland has been on full display during each of our three webinars, and we hope you found them as worthwhile as all of us do. And we do look forward to seeing you in Cleveland in the future. And Dr. Zein, thank you again for a really amazing and excellent presentation. And thank you very much.